Welcome, everyone. My name is Matthias Prokop from Nijmegen in the Netherlands, and I wish you a very interesting next hour. We will talk about AI-driven workflow in the COVID-19 area in this industry symposium by Canon Medical Systems. We all have been battered by COVID-19, and we'll see a host of new technologies that can help us win in these difficult times. We'll start with Dr. Mark Conn from Bradford in the UK. He will talk about relocatable systems, providing flexible solutions for difficult situations.
Thank you, Professor Prokop, for your kind introduction. Thank you, Canon Medical, for asking me to speak at this event. And thank you to the audience for taking the time to join me in this symposium. I hope you can all see my screen. I would like to share with you how Bradford teaching hospitals have used Canon Medical relocatable systems in 3 different areas over a number of years, namely expansion of service in a difficult location, maintaining workflow by providing a temporary cover of service, and more recently, dealing with challenges posed by COVID pandemic. Our story starts with a little history. Our radiology outpatient department is located at St. Luke's Hospital. St. Luke's Hospital was originally built as the Bradford Workhouse Infirmary in 1852. The current radiology department is housed in Blocks C and D, and these were added in 1860, over 150 years ago. In 2014, Bradford teaching hospitals realized that they needed to increase outpatient MR capacity. Being a Grade 2 listed building meant that we could not alter the structure of the building, and asbestos in the basement made it too expensive to strengthen the floors to take the weight of the MR scanner. The solution, therefore, was a relocatable scanner housed in the space between 2 blocks of the old workhouse building. This has provided a reliable and stable environment for routine outpatient scanning for over 6 years. Even as we come to the end of this scanner's life and need to consider a new replacement scanner, our building's estate has not changed, and neither have the building regulations. We commissioned work to look at strengthening the floor in one of the old blocks, but found that the asbestos lining in the basement would cost over £1 million to make safe. So it is likely that we will be replacing the MR scanner with another relocatable one, most likely in the very same spot. The second scenario where we have found a relocatable scanner invaluable is when replacing or updating CT scanners at our acute hospital, Bradford Royal Infirmary. We have 2 CT scanners on site, providing acute services for 800 inpatient beds and a busy A&E department. Any downtime in CT causes a backlog to our inpatient work. As a referral center, our prime SP has been reinstalled 3 times in the last few years. To maintain workflow over the 6 weeks or so when exchanging scanners, we decided to provide alternative imaging capacity by commissioning a relocatable scanner. We have designated part of the parking space between our radiology wing and the adjacent accident and emergency block. We installed water and electrical services, and when the time comes, we block off car access and car parking. The engineers deliver the relocatable box at 5 a.m. in the morning on the back of a truck. For this model, no cranes are required, as the relocatable has its own legs, which lift it off the truck bed. The truck can drive away, and the legs lower the whole box onto leveling blocks at ground level, all within an hour. In 2018, we installed an Aquilon Genesis 320 wide detector scanner using the same relocatable to maintain workflow. However, our greatest need for additional capacity has been during the COVID pandemic. At the beginning of 2020, the COVID pandemic arrived in the NHS. In an attempt to prevent the NHS from being overwhelmed, the British government ordered a lockdown, encouraging people to work from home wherever possible. All unnecessary travel was banned, shops were closed, and the scared public remained at home for the most part. In our hospital, radiology routine imaging was halted. Staff were sent home to protect the workforce. This included radiologists who could report remotely from home, but they also freed up radiology staff to contribute to turning prone patients on intensive care units. We call ourselves the Raptors. As the first wave progressed, our hospital was being rapidly filled with COVID-positive patients, more and more of whom required CT imaging, and also inpatients who needed CT imaging for other medical reasons. They were found to be increasingly COVID suspected or COVID positive. You may appreciate that in the early era of poor availability for COVID testing, asymptomatic patients had to be kept separate from COVID suspected patients and also from patients who had tested positive or were clinically positive, according to current clinical guidelines. With 2 CT scanners side by side in the main department, it was increasingly difficult to separate COVID negative green patients from COVID suspected amber patients or COVID positive red patients. Bradford Teaching Hospitals approached Canon Medical to see if we could acquire a relocatable scanner. And thanks to our relationship, we were able to locate a Prime SP scanner, which was located in its usual position by mid-April 2020. Located outside in the car parking area, it would be designated the green inpatient scanner, while the indoor scanners were designated red inpatient scanners. As you can see, there is enough room for inpatient trolley or gurney. The newest relocatables are equipped with Aquilon Prime SP, complete with ACE technology and cardiac CT capability. This relocatable was installed at ground level with only a small ramp required for trolley access. There was a short 20-meter walk outside from the radiology corridor to the relocatable entrance, so we reconstructed a covered walkway to protect inpatients during transport from the wards. Luckily, it was spring and the British weather was not too unkind. It took the Bradford population rather longer than most to clear the virus, perhaps related to multiple generations living in one household. Our first wave plateaued for more than 2 months before showing signs of declining. However, as the year progressed and COVID inpatients reduced, imaging at Bradford hospitals was allowed to return to full working capacity. The previous months had seen us turn off all routine imaging, so we had a tremendous backlog of outpatient work to catch up. Once again, the relocatable came into its own. We repurposed the relocatable to scanning outpatients this time, keeping void outpatients separate from the inpatients. We hired extra staff to scan into the evening and weekends. And with this added capacity, by October 2020, we had caught up with our big backlog, well in advance of many of our neighboring trusts. I call this our catch-up phase. Winter is a busy time for the NHS every year. But this year, winter 2020, the NHS decided that we would have to continue business as usual without cancellation of normal activity. The 7 Nightingale hospitals dotted around the country had not been used. NHS ITU departments were not overwhelmed, as we had feared, looking at the experience from other countries. So despite the predicted second wave of COVID, we would be expected to maintain normal outpatient activity, including fast-track scanning for suspected cancer and urgent CT scans. And we therefore justified the extension of our contract with Canon Medical for another 10 weeks. The relocatable allowed us to increase capacity for scanning inpatients and outpatients. All this with extra long appointment times to allow for cleaning and to avoid crowding in our limited waiting areas as patients arrive early or have to wait for post-CT contrast observation. This positive CTPA scan in a patient with COVID was acquired on the AT detector Aquilon Prime SP. using 50 mils of IV contrast, reconstructed with the ACE engine, and is displayed with noise-free 1 millimeter axial sections. Happily, we have survived winter and the second wave without collapse. Most of our radiology staff have remained well, and we have maintained a full radiology service. As we look forward to the post-vaccination era, we anticipate that patients who have been sitting on pathology will begin to return to see their doctors and require an increase in imaging. We have now had an additional third CT scanner on our acute site for a full year, and COVID is likely to mean new ways of working for us. In recognition of the need for increased capacity, our Chief Operating Officer has asked us to put together a business case for a fixed third scanner to take us forward in the post-COVID era. I think you can see how we have found the flexibility of a relocatable service to be an essential resource to maintain basic services when faced with limitations of infrastructure. It provides a convenient means for temporary maintenance of workflow when exchanging CT scanners. But most recently, for the entire year of the COVID pandemic, it has enabled us to maintain a safe service and provide extra catch-up capacity while we look for more permanent solutions in our difficult NHS. Thank you for your attention. Back to you, Professor Prokop.
Thank you, Dr. Kahn. I think it's very interesting to see how the added flexibility helps you really keeping up your service in these difficult times. When it comes to image quality, you already mentioned ACE, and we will have another speaker, Dr. Richard Hawkins from Crewe in the United Kingdom, who will give us an idea on how that actually helps us provide optimum image quality at very, very low dose. Dr. Hawkins.
Thank you for your introduction, Professor. Ladies and gentlemen, my name is Dr. Richard Hawkins, and I'm a consultant radiologist at Leighton Hospital in Crewe. I would like to thank Canon and the ESR for inviting me to speak at this session and to share with you my excitement at how artificial intelligence is revolutionizing image quality and dose reduction in CT. Our journey into the world of deep learning CT reconstruction began when our oldest scanner was replaced in the summer of 2019 with the Canon Aquilium 1 Genesis edition. Crucially, it was equipped with ACE, Canon's revolutionary new deep learning reconstruction technology. So to understand this better, let us quickly recap the history of imaging reconstruction. First came filter back projection. This was fast because it made many assumptions to reduce computing power, which was scarce, but it also gave the highest doses. Because it has been around for so long, these images are what most radiologists know and prefer to look at. Next came hybrid iterative reconstruction. This appeared in the mid-2000s as it required more computing power. It produced significantly lower doses, but the images had a different waxy look to them, and therefore it was blended with filter back projection images to make them look more acceptable, hence the hybrid tag. Next came full model-based iterative reconstruction. This gave very low doses indeed and much higher image quality by modelling every aspect of the imaging chain, but this needed vast amounts of computing power, so the process was very slow. For example, in the early days, it took nearly 2 weeks to reconstruct just one scan. Another issue was that the images looked plastic or as if painted by watercolours, particularly in the abdomen, and many radiologists disliked this. So the golden triad of high quality, high speed, ultra low dose CT imaging has been an elusive dream for a long time. Previously, only 2 of these 3 parameters could be achieved at once. That is, until the advent of deep learning reconstruction in the form of ACE, when finally everything became possible. This was revolutionary and a turning point in CT image reconstruction. So what is ACE? Well, ACE stands for Advanced Intelligent Clear IQ Engine. As a radical departure from previous methods, it uses artificial intelligence to remove noise during image reconstruction and enhance the underlying true signal. And this was a world first for Canon. ACE uses deep learning, a subset of machine learning, which itself is a subset of artificial intelligence. Deep learning systems do not need to be explicitly programmed, but learn a task through experience by being given lots of examples, much like a human learning a new skill. The key is the deep convolutional neural network, or computer brain, if you will. This mimics both the organisation and operation of the human brain. Such systems have taken the world by storm in the fields of speech recognition and facial recognition, and are now being used in numerous other areas. So how does ACE work? Well, there are two key stages, the training stage and the operational stage. The neural network is initially trained by showing it thousands of sets of matched images, one ultra high quality, the other low quality. Through the deep learning process and by millions of adjustments to its neural connections, the system teaches itself how to remove the noise from the low quality images and transform them into the high quality ones. This occurs under controlled conditions in a computer lab in Japan. When the system is considered to be optimally trained, it is fixed at that point and cannot learn anymore. The system is then shipped in this state and once on site switches to the operational stage, transforming the low quality ultra low dose data acquired into high quality images by removing the noise and boosting the true signal, just as it learned in the lab. You can see this more easily in pictorial form on this slide. ACE differentiates noise from signal. It removes noise, preserves image texture, improves low contrast resolution, and improves spatial resolution. In addition, ACE images have a more natural look to them than iterative reconstruction images, a look which is distinctive to deep learning reconstruction and seems to be much more acceptable to radiologists. Certainly so far, I've had no complaints from my colleagues. Now, huge computing power is required to reconstruct these images fast enough for everyday real-world use, particularly in the inpatient setting. Fortunately, the cost of high-end computing power continues to fall, driven by the insatiable demand from the gaming industry and the quest for driverless cars. Canon deliberately went into partnership with computer graphics giant NVIDIA to solve this problem. The solution? The ACE server, a supercomputer inside your scanner, as all reconstruction on Canon systems is done on the scanner itself and not offline. The result? A staggering 71.2 teraflops of power from 8 high-end NVIDIA GPUs working in parallel. To put this in context, the brand new Xbox Series X has 12 teraflops of power, nearly 6 times less. So how does ACE perform in the real world? Well, we were lucky enough to be one of the very first sites in the UK to use ACE back in 2019. So our goal was simple, to push the boundaries, exploit the full potential of ACE and prove its benefits. In fact, it surpassed all our expectations and has redefined what we thought was possible in CT, particularly in terms of image quality and dose reduction. More recently, in December 2020, amid the resurgence of COVID in the UK, we went live with our new inpatient Aquilion Prime SP, also equipped with ACE. Image reconstruction is not as fast as the Genesis, but has proven to be completely robust on this busy inpatient scanner and still provides the same level of image quality and dose reduction as the Genesis. We've been very impressed by its performance, proving that this technology is affordable, accessible, and usable across the full range of Canon CT scanners, and not just exclusive to ultra-high-end CT. So let me take you through a number of clinical examples now to give you a glimpse of the capabilities of this groundbreaking technology. An obvious place to start, where dose reduction is paramount, is the scanning of children, and ACE does not disappoint. Here is a volumetric CT renal angiogram on a 12-year-old with severe hypertension of unknown cause. The dose length product, or DLP for short, was only 10 milligray per centimetres or 0.15 millisieverts, equivalent to just 7 chest x-rays and less than the dose of a plain film. And here is a dual-phase trauma CT performed on a 7-year-old girl who sustained abdominal injuries after going over the handlebars of her bike. The DLP for the arterial phase was just 19.7 and only 32.2 for the portal venous phase images. That's a total DLP of 53.3 or 1.1 millisieverts, which is astonishing for a dual-phase study of this quality at this dose. Another of our initial targets was urological CT examinations, because CT KUBs and urograms are very common. A large proportion of the patients are young, and many will require follow-up scans accumulating dose along the way. So we developed what we like to call the ghost dose protocol, because the doses are just so incredibly low. Using ACE, our mean dose of 78.5 is 82% below the UK national dose reference level of 440 and less than the dose of a plain film. So we would argue that the plain film KUB is now extinct, and it certainly is in our department. So here is a ghost dose CT KUB. The DLP is only 37.5 or 0.56 millisieverts, less than the dose of plain film. On the left is the ACE image, and on the right it's the same image reconstructed with filtered back projection. And you can see it's so noisy, it's completely unusable. Here is a follow-up series of CT-KUBs. On the left is the GHOST dose study with a DLP of just 67, and on the right, the previous study using iterative reconstruction on an older scanner with a DLP of 416. So on the same patient, that's an 84% dose reduction, yet the image quality is better. The GHOST dose protocol has also been applied to CT urograms. Currently, we still use 3 phases, but despite that, our mean dose of 401 is 65% below the UK national dose reference level of 1150. And here's an example. Here's the initial KUB phase. On the left are 0.5 millimeter ACE images, and on the right, 1 millimeter iterative recon images from the previous study on an older machine. And even at half the dose and half the slice thickness, the images are better. And here are the portal venous phase images from that same study. And last but not least, the urographic phase images. Now, bariatrics is another area where ACE excels, and we're in the process of trying to quantify this more accurately. Now, here's a CT chest, abdomen, pelvis on a huge patient with a BMI of 69. The DLP of 1250 is exceptionally low for a full body examination of this quality on a patient this large. So on the left are the ACE images, whereas on the right are the images reconstructed with filtered back projection. Once again, you can see they're so noisy, they are unusable. Now, CT pulmonary angiograms are another very common examination, but during the pandemic, we've seen the numbers skyrocket. With ACE, our mean DLP of 117 is 73% less than the UK dose reference level of 440. Here is a spiral CTPA performed on a large man with our new Prime SP. A saddle PE and COVID are clearly shown, and yet the DLP is just 109 or 1.53 millisieverts on a large patient. In fact, the recommended COVID protocol in the UK of an unenhanced CT chest followed by a CTPA is precisely what's required to produce sure subtraction lung perfusion images, and this has now become the norm on our Prime SP scanner. Here is one such study demonstrating florid COVID, but also a P in the right below, which is much easier to spot with the help of the perfusion maps. And yet the entire study, pre and post contrast, was performed for a DLP of just 77.7 or 1.1 millisieverts. Now, a special subset of CTPAs is those performed on pregnant ladies. With further optimization, we've driven the dose down even more, and our mean DLP of 29 in this group is 93% now, 93% below national DRL. So here's a volumetric CTPA performed on a pregnant lady. DLP is only 14.4 or 0.2 millisieverts. That's just 10 chest x-rays. Now, during the pandemic, we also developed an ultra-low dose CT chest and KUB protocol after advice was issued to scan the chest in patients presenting with abdominal pain because COVID fooled us so many times in this regard during the first wave. Now, here's one such study, and the DLP is just 98.5 or 1.48 millisieverts. That's 90% the national dose reference level of 1,000. Whole body imaging of this quality at such low doses was previously impossible in the inpatient setting. And finally, CT coronary angiography has come to the fore in the pandemic as a substitute for invasive cath, as many patients were deemed not suitable due to COVID. Here's an ultra-low-dose CTCA performed on the Genesis with ACE. Despite a DLP of just 17 or 0.2 millisieverts, the image quality is superb. So hopefully I've given you a glimpse of what I truly believe is the future of CT image reconstruction. ACE will continue to evolve. Version 2 is already here, and as one of the first UK sites to be upgraded, we're seeing a clear increase in image quality whilst maintaining ultra-low doses. And with more computing power, ACE will become even faster and more sophisticated. But the images I've shown you don't capture the true quality of the images produced. The stills, you just can't appreciate it. You have to see them in real time. So I would encourage you to contact Canon for a demonstration or come to visit us, and we will give you a taste of the future. Now, finally, I'd like to say a huge thank you to all the team involved at Leighton, without which none of this would have been possible, and also to Canon Medical for their continued support. Thank you for your attention.
Yeah, thank you, Dr. Harkins, for this impressive talk with image quality that is quite amazing at these low doses. we'll move on to Dr. Benoît Doche from Bordeaux, who will talk about similar applications in the area of MRI.
Hello, thank you for the invitation. So I will talk about daily practice of ACE and compressed speeder in neuro MRI application. I'm working in Bordeaux in a private practice in a medical group called IMAGIR. And I have a collaboration with Bordeaux University Hospital in the field of epilepsy and neuroinflammatory disease. So I'm working on MRI Canon, Vantage 3T Galant. On the hardware part, I use an 8 cores of 42 elements and advanced gradient of maximum strength of 45 millitesla per meter. And on the software part, which is a focus of this talk, we will talk about ACE, the deep learning reconstruction on MRI, and advanced acceleration technique like compressed speeder and multiband speeder. So ACE is the first deep learning reconstruction for scanner, as we've seen, and also for MRI. So it's based on artificial intelligence, and it's based on machine learning and deep learning. So we use deep convolutional neural network, artificial network, which have the capacity to learn by the network. So there is a training phase for ACE in MRI. So the algorithm is fed with low signal to noise input images with training, and it has a target of a high IQ target, high image quality target, which is acquired with 10 average. So from low signal to high signal to noise ratio. So in your clinical practice, you will use a validated deep convolutional neural network, a trained network, which is easily integrated into your routine practice from data acquisition to ACE. So with a convolutional filter on the subtraction, you will lose some clinical information. As you see here, you have some anatomical details of the brain, the border of the brain, and you can see some details of the basal ganglia with a convolutional filter. But with the ACE on the subtraction, only the noise is present. So there is no missing clinical information. So example of normal situation, a 3D flare. Here with ACE, it's only 2 minutes 55 seconds, and you see that the cortical ribbon is well defined. The border between the white matter and the gray matter is clear, and the white matter is more homogeneous than without ACE, and the time without ACE of the sequences was 5 minutes 50 seconds. So there is a huge gain of time. That's another example of zoom on a temporal lobe with the hippocampus. On the head of the hippocampus, you are able to see some anatomical details, some internal architecture of the brain, and you can follow the low signal line here, which is the stratum lacunosum. So the resolution is better. You see that the white matter is more homogeneous also. It works also with FSBB, with susceptibility weighted imaging. Here with ACE, the time is only 1 minute 41 seconds. Before, without ACE, it was 3 minutes 48 seconds. And you see that you are able to see more resolution with some details of the basal ganglia, which is more clear, and the border of the brain also is more clear. And another acceleration technique that we will discuss is the multiband. It works with DTI. Here it's an example of a 12 direction DTI. The time is only 1 minute 16 seconds. Before it was 2 minutes 22 seconds, and you see that the resolution of the ISO diffusion is better. So with ACE, the reduction time of the acquisition in the more efficient situation is between 27% and 55%. For example, the sagittal 3D flare for multiple sclerosis is only 2 minutes 51 seconds now. Before it was 5 minutes 50 seconds. The FSBB is only 1 minute 41 seconds. Before it was 3 minutes 38 seconds. And the coronal 3D-T1 amperage, which I use for epilepsy, is only 1 minute 42 seconds now. It was 2 minutes 42 seconds before. So the other technique of acceleration we will talk about is the comprehensive sense. It's undersampling of the case space. is based on the regularization factor, which separate the information, the clinical information, the tissue signal, from the aleatory information, the noise. So it's a trade-off, because if this regularization factor is too high, you will miss some clinical information, some redundant information, and you will have more noise. So you need to be careful not to have a regularization factor which is too high. So again, a huge reduction of time of the acquisition, because in the more efficient situation with CS, you will win between 42% and 53%. For example, the sagittal 3D fast field echo, T1, is only 1 minute 29 seconds now. It was 2 minutes 40 seconds before. And 3D T2 center on the internal auditory canal is only 1 minute 30 seconds now. It was 2 minutes 21 seconds before. So the other acceleration technique on DTIs for the diffusion is multi-band. It's based on the simultaneous acquisition of two slices. So the acquired signal contains the information of two slices. So basically, you will win 50% of time. For example, this 12-direction DTI is only 1 minute 60 seconds. Before it was 2 minutes 22 seconds. And for advanced application, when I will do tractography, I use a 30 direction, and it's only 2 minutes 28 seconds now. So it's very much better. So an example of ACE DLR, deep learning reconstruction for it's a glial lesion of the frontal left posterior with a contact with a gyrus precentral. So with ACE, only 2 minutes 51 seconds, the lesion is more clear, the intensity is more homogeneous, the borders are more defined. It's only 2 minutes 51 seconds. Also with 3D T1 with injection, it's only 2 minutes 48 seconds. So there is a quality here because there was a surgical biopsy which was not contributive. You see that there is no gadolinium enhancement. There was a longitudinal follow-up. So here you see that there was augmentation of the lesion of the anterior and superior part. It's based on the difference of intensity on the flare. So you see here it's more easily because it's a complex lesion. It's not always easy to have a good impression of the progression of the lesion. So as we save time, we have more time to do advanced applications. So in this case, it was possible to do T1 perfusion, DCE. The map of the K-trans is normal. There is no augmentation of permeability. And we have done also T2 perfusion, DSC, and there is no augmentation of RCBV on this map of RCBV. So clinical case for component sense, it's the case of a vestibular schwannoma on the right internal auditory canal. You see the lesion on T1, the enhancement on the T1 after gadolinium. It's only 1 minute 29 seconds. And on the 3D T2 center on the internal auditory canal, you see the lesion here in the internal auditory canal, and it's only 1 minute 30 seconds. So in less than 4 minutes, you are able to do a full diagnostic, a full follow-up of this schwannoma. Just to talk about the routine protocol, it's only 6 minutes 49 seconds with a sagittal 2D T1, 3D flare 2 minutes 30 seconds, FSBB, time of flight, and DTI 12 direction. It was a case of headache, and by accident, we found a cavernoma on the right cerebellum with some venous structure around the cavernoma, so developmental venous anomaly. We had time because it was only 6 minutes 49 seconds, so we have done an advanced technique and ASL, and so the ASL is negative. There is no hyperfusion on the lesion. The time of flight show no communication between arterial venous system, so we are sure it's just a developmental venous anomaly with a cavernoma. So the perspective of all this, there is a gain of time, a gain of resolution. So you can improve the patient workflow, you can improve the diagnostic quality. So it's a balance between all this. So more time available for more sequences of more patients. It's a good thing because you will ameliorate the waiting time of a patient to have his examination, and you could do also better quality imaging because you have more time for advanced application like spectroscopy, perfusion T1, perfusion T2, or ASL. And all this acceleration technique, CS or multiband speeder and the DLR, you will be able probably in the future to win more time because it's a possibility to combine the DLR and the CS. Possibility also to combine the DLR probably with a synthetic MRI, one acquisition multi-ponderation, and the ultimate goal of this is probably to try to do with a 3T magnet the quality imaging of a 7T magnet. To talk about workflow, this is an example at 3T of a vacation considering the gain of time with DLR and CS. We'll try to do one advanced application in 30 minutes, so maybe with spectroscopy and perfusion, and after to save time because with in 15 minutes we are able to do more simple examination with no injection. For example, the routine protocol is less than 7 minutes, and the epilepsy protocol, which is quite complete with a 3D TMPH, FIBB, a 3D flare, DTI is only 8 minutes and 30 seconds. And this is another example of improving workflow at 1.5 with more simple case. We'll try to do one examination per 15 minutes, so 4 examinations an hour, by rationalizing the vacation between an alternance between 2 examinations with injection and 2 examinations without injection. And so this is just this is the box where the algorithm is located, just to show you that it's just another box, and all this is an easy integration in your clinical practice. Thank you for your attention.
Thank you, Dr. Doche, for these interesting and impressive reductions in scan time while really improving image quality, both in terms of noise as well as in terms of spatial resolution. And I'll move on to Dr. Manuel Mignonm, who will talk about another issue in the COVID area, namely what happens if you really change your equipment. And he will share his experience with switching in for the angio suite during COVID-19.
Thank you, Professor Prokop. My name is Manuel Mignonm. I am a radiologist, an international radiologist, and Canon user since 2020. This is my disclosure. And on the map, you can see the localization of my hospital in Belgium, in the south of Belgium, between Waterloo in the north and Nijmegen in the south. This is a view of my very old hospital. You can see the activity. And I work in a team of 24 radiologists. This is a panel of our material. And this is my personal situation during 10 years until 2080. I was alone for interventional activity, not really dedicate room and increase activity. So not so bad, but not enough for me and for the institution. Because we increased our activity, hospital management understood the necessity to invest in a dedicated room. I was present in Vienna, ECR, in 2018, and I was there for meet many firms. I remember I was very positively surprised by the Canon solution with Alphenix 4D CT angio. It was exactly what we need. It was the kind of equipment that perfectly fitted our way of working. So my department chief, Dr. Desley, and I needed to convince the hospital management to invest for the product because for us it was the adapted product right now, not in 10 years. So why Alphenix 4D CT angio? For us, it was an evidence because it's the best for patient care and it's the best clinical system for better efficiency for radiology department and the institution. What about the financial point of view? We made a business plan and the conclusion of our hospital management was do it. So with this ambitious project, we jumped to the future. the first integrated room in Belgium. Installation began in November 2019, and it was really challenging because some difficulty, because a very hard installation and hard building. But we were very confident and very exciting until March 2020. The timing was respect. I was happy on holiday with friends in France, and I didn't know it was my last holiday out of Belgium until today, because you know, COVID-19 pandemic starting in Europe, and quickly the Belgian first lockdown. So after enthusiasm, we feel very sad and isolated, lost in translation between past and future, like many people in the world. Of course, major activity in the hospital was dedicated to COVID-19 patients. We were very implicated with the radiology department. But my question was, how do we manage the activity between the previous and the new room in this condition? So challenges were how to complete the installation of the Halphenix 4D CT room. And the second question was how to start an activity in the new 4D CT angio room. Last but not least, how to make transition between the previous and the new room in this condition. The key of the solution was thinking outside the box and thinking differently about the future. So, hospital management and Canon team were convicted with the strategy to finish the installation quickly in lockdown restriction. Canon medical team helped us with very intensive local training of the teams, and we established the calendar you can see here. Canon my hospital management to open new room every day in April. We perform CT exams COVID-19 patients first to discharge other colleagues. We perform a procedure using angiography then. We manage dedicated activity for emergency, diagnosis and treatment using US CT angio if necessary for abscess treatment or polytrauma with organ bleeding, for example. This organization during crisis discharged rapidly our colleagues from radiology and emergency department, and it was very appreciated. So what about the results? We rapidly restart normal activity between the first and the second Belgian lockdown. The competitive low dose of the Halphenix 4D CT angio is very appreciated. We are more confident with dose with efficient combination of spot fluoro with angiography. And we particularly like this angio combo to perform chemo treatment and ablation treatment. The configuration of our CT angio room is perfect for that. So rapidly, clinical example using 4D angio CT. You can see the lesion on the fibrotic liver, wash-in, wash-out, hepatic carcinoma. We decide to treat the lesion under general anesthesia. We perform angiography first and angio-CT to target the lesion. And we deliver the local treatment by chemotherapy using combo guiding. We move again to CT for an additional treatment. By thermoablation, and we put the needle easily under fluoro CT. And finally, a perfusion study was performed with angio-CT, and you can see the results of the treatment. I think the treatment was very nice, in my opinion, in only one session. Switching from CT to angio and to angio to CT is very, very easy and very fast. And now success is there, because we enjoy the Halphenix for the CT angio every day. And this choice was definitely the best choice for us, because we appreciate the facility of manipulation. We easily switch from CT to angio. It's very crucial for emergency activity when we jump from CT diagnosis to treatment and angio in the same time, for organ bleeding, for example. It's also very precious for innovative treatment like pancreatic chemotherapy. In conclusion, it was an ambitious project in lockdown condition, with exceptional work of Canon and hospital management. Hand to hand, the calendar was really respected, with exceptional local and intensive support for training. Teamwork was, in my opinion, the key for that success, and Canon integrated really well into the hospital. Thank you for your attention.
Thank you, Dr. Mignonm, from this experience from La Louviere. Interesting that in the middle of the biggest seat, you were able to get that done. It is quite impressive. We'll now finish up the 5 talks with Professor Fischer from Berlin, who will talk about ultrasound and also the use of AI to speed up and improve quality of the images.
Dear Chairman, ladies and gentlemen, this is my active disclosure. I'd like to give you a short introduction. We have to briefly outline the possible indication for new ultrasound techniques and applications, especially in terms of AI. A short introduction. On your left, this small guppy is a tropical fish and one of the most popular species worldwide for freshwater aquariums. Hopefully on your right, AI is ready to subdeviate into male infantile tube C or female triangle type B, which is a possible indication for AI for the future. This is an overview on our interdisciplinary ultrasound center, which is headed by the Department of Radiology. We are subdivided into the Department of Surgery, including the departments of ear, nose, throat, surgery, orthopedics, and urology, the internal medicine with the outpatient service, oncology, nephrology, and rheumatology, the emergency medicine with cardiology, anesthesiology, and the emergency department itself. We have a very close cooperation to the research lab, and I'm the head of the Ultrasound Commission. As the Ultrasound Center already had a close cooperation with the team of emergency physicians before the pandemic, headed by Professor Möckel, we intensified training in lung ultrasound for physicians of other specialties. Hardware is very important. On your left, COVID positive. We use dedicated scanners and dedicated rooms for COVID-19 patients, disinfection with suitable clothes after every patient. A work list could be generated via a VLAN interface, and the reporting could be supervised by radiologists via our own hospital PACS. On your right, COVID negative, only phone registration, only scheduled examination of outpatients, and automated disinfection after all interventional procedures. On your left, this is a view on our dedicated COVID-19 ward at the moment, including 110 patients in this building. On your right, a standardized scoring sheet for lung ultrasound. We have to use this lung preset. All cosmetic filters are off. The focus point is adapted to the plural line. The gain is adapted to avoid saturation. We use a very high frame rate and the penetration depth of 13 centimeters. From the first wave, our training case, including CT examinations, We have first on your left A lines, which represents regular lung parenchyma. We see the small subpleural consolidation on your left. We have discrete B lines on your right, and the pleural thickening with confluent B lines in this short video clip. Coming to the new ultrasound techniques and applications, and starting with the Department of Surgery and color-coded duplex ultrasound. Thomas, really? Color-coded duplex ultrasound, that's new? Definitely not. But we have these very nice formula, getting a 100% sensitivity to see the stenosis in the celiac trunk, which is very important. And new is that we have to analyze the contour or shape of the so-called hook stick, which is possible with MR angiography, as well as the view on the Da Vinci assistant robot surgery on your right. This is how it looks like in the ultrasound examination. Smart 3D, which is a technique which is driven by AI before and after the operative procedure. And hopefully for the future, we get these nice results also in 4D evaluation. Next step, what is the ultrasound? What is MR? Not so easy to discriminate, and this is important to understand that sometimes we have a compression of the ganglion, like in the image on your right, which is beautiful, visible in a 3D examination. This technique is also very useful in professional athletes. This is an example of the so-called patellar tips syndrome. On your right, you can see before and after therapy, a reduction of the ratio, which is analyzed based on 3D automatically. Power Doppler evaluation on your left, and SMI Doppler evaluation, which is superior to see also these very tiny vascular architecture and perfectly reconstructed, artifact-free in 3 dimensions. Internal medicine. This nice publication from 2019 in Radiology with the Bosniak classification update for cystic renal masses. But the statement from these authors, the role of ultrasound is uncertain. Really? The reason is we have to use standardized protocols also for CT and MR. That's very important to understand. But ladies and gentlemen, life is definitely no picnic like in the pandemic. So therefore we need SMI as well as contrast enhanced ultrasound for our daily lives business, because routinely we don't get in every case these standardized protocols. This is a nice case example on your left CT scanning. It's not easy to depict these tiny septae, which is much better in the MR in the mid. And on your right, the ultrasound evaluation of the same patient for the follow-up scans. This is published running out of our department, these data, pretty nice. And last but not least, AI technology to use the adaptive sum of the contrast inflow to see especially these very tiny septae. Next step, AI can make ultrasound exams more efficient and faster. Measurement, that's important to know, B-mode scanning. Complete analysis of the volume of this cystic lesion with different layers. And on your right, this technique is also possible for contrast enhanced ultrasound. Next step, AI for prostate cancer detection. That's brand new, and here you can see the schema of our workflow. And I'd like to demonstrate this workflow in my business. On your right, starting with 2D evaluation and 3D evaluation of the prostate, that means ultrasound fusion. Next step, to load the ultrasound volume data and integrate these data or have a combination with the MR scanning, to put a button to make an automatic registration to have the right scan plane available, which is absolutely necessary and important and very fast. Next step, region of interest, and you can see the small hypoechoic nodule or hypointense signal in the T2 weighted examination, 7 millimeters in size. And next step, to get material from the lateral, from the mid and medial position of this small tumor. We get also the contour of the prostate and the volume. And it's possible to make this target image after the procedure. If the patient is coming back, we can see all these targeting points very nicely. The short outlook, fatty liver, inflammation, fibrosis, cirrhosis, and HCC. That's very important in our daily life. And so we start with the steatosis, and you can see here a very high value of the attenuation imaging, in this case of a steatosis. Next step, B-mode scan looks quite normal. But on your right, we see a higher shear wave dispersion measurement, meaning a higher viscosity, and this is related with an hepatitis in that case during a study therapy. Next, fibrosis or cirrhosis, we get a very high value for the shear wave elastography evaluation, a lower value for the viscosity measurement. And HCC, early enhancing tumor, hyper enhancing, and we see the washout is beginning after 60 seconds, which is absolutely typically for this HCC. And so we can use the Zoyce-Lyritz classification system pretty nice. In summary, we have seen very small object. We have to use contrast agents and AI for the future to get these very nice results. Hopefully integrated to 4D and 3D evaluation, also based or driven by AI technology. But at the moment, reality is so beautiful. And with this last video clip from my beautiful swan here from the celiac trunk, I have to say thank you so much for your kind attention. Thank you.